Good morning, guten Morgen, bonjour und habarisa subui. Salama. It's my first time here at the Republica, and I must say I'm really impressed. It seems to be a really, and I hope the team agrees with me, it's really a fun and inspiring event to be at, and we really hope that our presentation will contribute to the forum and give you a good feel of how digital technologies have become a really important issue in delivering healthcare in low and middle income countries. So on behalf of the Innovation Factory, I'm happy to welcome you all to the session on connecting health, systemic mHealth solutions for better pregnancy and birth-giving care. What we will talk about today is how digital technologies can help overcome a challenge that is really close to the heart of everyone that is representative, and that is mothers and children. What I want to start this session with is a story that I was told while working in Tanzania. It's a story that really could have happened in any of the countries that is represented here, and I hope it gives you a glimpse of why we think this is so important, why we want to present the work today. What I'm going to say is going to be followed by 2 presentations and a panel discussion at the end. So the story is about a young pregnant woman living in southern rural Tanzania. She's 20 years of age and she's pregnant. And when she felt her first labor pains, she did what was common in her village. She called the traditional midwife. And for the next 11 hours, she would be lying on the floor of her small house, and the pain with hours passing, getting more and more unbearable, and the birth not progressing. So eventually the midwife did decide, together with the family, to bring her to the next dispensary accessible by road. She was carried by a wheel cart. You have to imagine these are streets, not streets like we know. Those are little footpaths that we're talking about here. And by the time she got to the dispensary, a nurse was present and she immediately called the ambulance. But again, by the time the ambulance had come, another 6 hours of pain had passed for Dorothea. And by the time she eventually managed to get to the hospital, the doctor wasn't there. When the doctor came back, he delivered the baby, but it was dead. And, you know, this persistent high maternal and neonatal deaths and the resulting disabilities that women are facing in low and middle income countries are still one of the greatest challenges that we are dealing with. And what we are going to speak about today are really the concerted efforts by experts in Tanzania, Kenya, and Cameroon and Germany that are all striving for common vision, and that is that women like Dorothea can deliver healthy babies, and that pregnancy really becomes a matter of joy and not death. The ideas that will be presented today have been developed in the framework of the Innovation Factory, which is an initiative commissioned by the German Federal Ministry for Economic Cooperation and Development, and has been supported by the German Technical Corporation, GIZ. And it provides a collaborative space for health and IT professionals to make use of the innovation potential that digital technologies provide to support health systems in delivering quality healthcare services. What the initiative recognizes is that digital solutions, health solutions, are often developed in silos, in single island fashion, and that while they are successful, they don't have the power to make change to the health system, to create synergies. So the collaborative nature of ideation has really been at the forefront of this initiative. And in self-steered country units, experts, policymakers, civil society organizations, medical staff, community health workers, private and public sector have really come together to forward systemic e-health solutions based on the special needs of the countries and enhanced by local knowledge. So the process of ideation in these countries has been highly participatory, and it has been informed by local needs and backed with international support. All countries have done their own needs analysis. The composition of teams and the steering of the teams is very different. The methods for developing the ideas has been different. There's been hackathons, there's been use of design thinking methodology, and as diverse are the ideas that will now be presented by Stephen. I welcome Stephen to the stage. Stephen Wanyi. He's a member of the Kenyan country unit, and he's a biomedical information specialist with really a wealth of experience and hands-on experience in the entire continuum of care, from conceptualization, design, development, implementation, use, support, maintenance of digital health strategies. He has a really strong focus on standard-based interoperability of digital health systems. And Stephen will now be presenting the results of the ideation process of the African Innovation Factory team. So, Stephen, your turn.
Thank you very much. Good morning. Guten Morgen. Habari asubuhi. All right, so thank you very much for the kind introduction. So my name is Stephen Wanyi from Kenya, and as I've been introduced, I was involved in this process both for Kenya and primarily for Tanzania as well. So, but besides that, I'm really honored and privileged to be presenting on behalf of Kenya, Cameroon, and Tanzania. They're very capable presenters and representatives from those three countries here. So I'm really grateful for that they trust me to represent and speak for them, at least for this short session before we get the panel session. So I think as soon as we're ready, I'll get through the slides. I'll speak for a couple of minutes, and then I think we'll have a panel session where we can respond to your questions in greater detail. So generally, the context of this focus for digital health interventions was the reproductive, maternal, child, adolescent health within the three countries. And in terms of contextualizing your thinking, think about the continuum of care from the moment a woman determines that she's pregnant until the 5th birthday of her child. So the question then becomes, what can digital health or e-health do for that entire continuum of care in terms of reducing maternal mortality, child mortality, and morbidity? That's really the question that we're grappling with. And the Innovation Factory model helps us to think through how can we effectively apply digital health along that entire continuum to reduce maternal and child mortality and morbidity. So just in terms of context. So generally, the three concepts we're dealing with these challenges. And again, as has been mentioned earlier, there are a couple of similar challenges and also very different challenges in the three countries as expected. But these were the common challenges across the three countries. There's definitely limited accessibility to quality community and mother-child services. I think that's very common to most of us who've worked in those types of countries. And then weak communication and coordination between and across various levels of the healthcare system. So basically, the way healthcare is provided in these three countries, I think, as we know, is right from the national level to the community level. For example, in countries like Cameroon, the community level is very disengaged from the health facility level. And so there's a very clear disconnect in terms of service delivery between the lowest level, which is community services, and the next level, which is the health facility level. But also in Kenya and Tanzania as well, there is a huge disconnect vertically and horizontally. So continuity of care, referral systems, communication between patients and providers are not as effective. Literacy, again, is a big problem. Mothers don't know what to do when they get pregnant. They don't know the immunization schedule. They don't know when to go to the facility. Similarly, healthcare workers, particularly community healthcare workers, I think, as we know, are not formally trained healthcare workers. So they don't have the requisite skill sets and the competency and capacity to deliver quality health services. So again, there's an issue of literacy, both for the mother, young mother, and also for the healthcare providers. And lastly, we all know about data. Lots of data, but lots of challenges in making good decisions. A lot of decisions, unfortunately, in most African countries are based on authorities. Who are you? Not what is the evidence base. So again, that's a big problem that we're trying to deal with. And that's the justification for digital health as an intervention. So again, as was mentioned earlier, this was a rallying call or clarion call for the three countries that we want to make pregnancy and birth a matter of joy and not death. That really united the three countries, and we'll see later on in the slides, there is an opportunity for collaboration south to south, again, based on this common rallying call. So let's go to Cameroon. So Cameroon, and will be discussed later on in more detail in the panel, the main challenges around Cameroon were delays by the mother to understand when to best seek care, delays in terms of reaching the health facility. Again, as I mentioned earlier on, there's a clear gap in terms of services at the community level. So mothers are unable to access health-based facilities, care at the health facility. And then there's also a delay in terms of once they get to the health facility, how quickly and efficiently they actually receive healthcare services. So Cameroon dealt with delays, 3 delays, and we'll hear later on from Ms. Annie about those delays and how they affected their thinking in terms of developing the solution. But in terms of thinking about the solution, then a lot of the emphasis was on communication and collaboration. How do we connect the different parts of the healthcare service to ensure that the woman who is pregnant actually gets the information she requires to make good decisions, to seek healthcare in a timely manner. The community health worker is well equipped, with knowledge, with capacity, with skills to actually deliver healthcare services. And then, of course, the health facilities are well equipped. They have doctors, adequate trained healthcare personnel. They have equipment. They are well manned, and things like that. So we're dealing with that continuum of care in terms of connecting the healthcare services based on where those are provided. So the key objectives for Cameroon, basically in terms of using this model for Innovation Factory, were empowering women, again, as I mentioned earlier, to make informed decisions in a timely manner, to seek healthcare services before it's too late. Again, you had the story of Dorothy. So that was one of the objectives for that country. And also to ensure that the women seek antenatal and postnatal care services effectively. We know that WHO recommends at least 4 antenatal care visits. Now it's gone to 8. But we all know that the number of antenatal care visits by women in most countries is way below what's supposed to be. For example, like in Kenya, it's less than 60%. That's way below, and it's really a contributor to why so many women lose children, because they deliver at home, or they deliver under unskilled healthcare workers. So that's a big problem, again, cutting across the 3 countries. And then, of course, delay in the referral process. We all know about the need for effective continuity of care. People migrate for different reasons, and so there has to be a system that supports continuity of care. All right. And then the next idea is that Cameroon was hoping to improve the availability of quality information, the referral process, and, of course, providing better evidence for making decisions. Kenya had sort of 3 solutions that were integrated. If you look on the left-hand side, one of the solutions was trying to encourage or strengthen the cooperation process between healthcare workers. So this bottom picture here shows a community health worker who's listening to a mother to determine the state of a pregnancy, and above, a little bit more sophisticated, by a skilled healthcare worker. So cooperation between these 2 is important. That's at the health facility. This is at the village level. And then there's also the compliance in terms of following protocol for practice. Again, you find there's a skilled, trained nurse and unskilled community healthcare worker. And thirdly, the third solution was on patient-provider communication. So using and taking advantage of mobile phones to communicate with the pregnant woman. So these were the objectives in Kenya. We wanted to improve the client satisfaction, so the mother. We also wanted to improve the performance of the healthcare worker, and also improve the surveillance capacity of the health system. So once a woman gets pregnant, she's followed up until pregnancy and until the 5th birthday of her born child. We were hoping that through the Innovation Factory process that was very unique in terms of discovering, validating, and prioritizing the solutions using the collaborative requirements development methodology, we would come up with very innovative ideas, and I think we did that to a large extent. And also utilizing and taking advantage of digital health assets like mobile phones that most people have in countries like Kenya. And then also, given the interest in interoperability, contributing to the enterprise architecture thinking of the country. And lastly was Tanzania. So Tanzania is a bit different. Tanzania has fairly mature digital health systems, actually 3 systems that more we'll talk about later on. And this picture shows the first problem, which is fragmentation. So they have 3 major systems that are implemented in the whole country, but right now they're not well integrated. So each system communicates with the healthcare worker, who's at the bottom here, and also communicates with the pregnant mother, and they all try to send data to the National Health Information System. So lots of fragmentation and lots of problems because of that purpose. Now, their solution was to integrate this using interoperability. And generally what this second picture shows us is using, for example, an interoperability framework like Open Health Information Exchange. you're able to integrate data and also interoperate systems in a way that ensures sharing of data and continuity of care. So that's basically what the second picture is trying to do, and that's what they're really working hard on with leadership from Ministry of Health. And that generally, the hoping is going to lead to happier mothers and generally happier health communities. So they have a very well mature mHealth community of practice. And these were the objectives of Tanzania. Again, basically integrate systems strongly because that's a big problem there. Reduce pilotitis, which is everyone coming with different or similar ideas and trying them on the same patients. And then, of course, working very closely with the Ministry of Health. And through this, they hope to aggregate data, use it better, and make it more available. And through collaboration, solve bigger problems. So we have a bunch of opportunities. This is actually a welcome slide to all of you that might be interested in working with the different countries. We have fairly mature concepts. We have fairly mature implementation plans that we can engage with different people who are interested in working in these 3 countries. So, feel welcome to speak with any of us about that part. Conducive environments, given that we work with governments, all these innovations are led by government, the Ministry of Health, very strongly. So we're well entrenched in that system. So we have a fairly, I would say, conducive environment to implement these systems and even more systems. Interoperability is a big problem in 3 countries. So if you're an expert in interoperability and integration of systems, again, I think there's an opportunity to work in the 3 countries. People who work well in open communities of practice, again, big opportunities there as well. If you're in capacity building for healthcare workers, that's a big challenge also that's ongoing. And then if you're in research, implementation science, research and evaluation, again, lots of opportunities to do research and inform practice. And these are just a bunch of ideas, but we're also hoping that you can share more with us. Thank you very much. Those are the contacts.
Thank you, Stephen, for this great presentation. Now that we've heard from the 3 African countries, I would like to introduce to you Mr. Titus Kuehne, who is the key person for the German country unit, who, like the other teams, have undergone a similar ideation process, and they've come up with a wonderful idea that he will now present. Mr. Kuehne is director of the Charité Medical University Institute of Computer-Assisted Medicine. He's a physician at the German Heart Institute in Berlin, and he is the CEO of a company called eMedical Communications and involved in product development, project management for digital health solutions. Welcome, Mr. Kuehne.
Yeah, thank you for the introduction, and Steve, thanks for the brilliant talk. And I'm just looking for mine now. Should be following yours, but it does not. I think we have to change the PowerPoint presentation then. Okay, great. Thank you very much. Nearly. That's okay. I think this is a small room here, and everybody who has problems seeing the slides, there's some space in the front, so I think we take that one. So maybe just to have a short view back, historical view about what is digital health means in the context of international development and humanitarian aid. So if you look at the colonial period, I think the focus of these actions in terms of aid and international development were very much on tropical medicine, which evolved then more step by step to international health in the cold and immediate post-Cold War area, where the family planning aspects, like Stephen presented that already, came a little bit more on the screen, and the first health services were established. This was then followed by something which I would like to call the Global Health 3.0, where we have more the focus, and that's the current time, on more global and system diseases, like which pop up also in these countries we are talking about, like tuberculosis, diabetes, HIV, and so we have to take account much more complex diseases also than just the tropical disease elements which I mentioned before. And when we are thinking about Global Health 4.0, which becomes reality hopefully soon, we need to tackle things which are much more depending also on technology and linking different institutes together. So a single university or a single health center will be not able to tackle that when we're talking about patient participation, like in the mobile health area, linking data together, as Stephen also mentioned, that particularly for the Tanzanian project, to aggregate data into one platform to make really powerful use of that. And that's what we would like to call Global Health 4.0, actually. But let's step back now. We have a lot of problems before us before we can talk about Global Health 4.0. We have large amounts of data, yes, but they remain unused very often. We have a lack of data which we can collect, of course, in the remote areas. In the cities it works pretty well, but we have something which we call digital divide. The more remote things are, the more difficult it becomes to really get high quality data also. So the quality data must be taken, there must be taken a question mark anyhow always behind it. Is it really helping me? And then we have the lack of interoperability. Stephen just presented 3 projects in Cameroon, in Kenya, and in Tanzania. Each of this project consists of many other projects. So we have a hugely fragmented landscapes of different solutions. And this is also very important. This is driving costs tremendously. If we are not able to reach a kind of critical mass and to homogenize our solutions, we will end up spending a lot of efforts and money into island solutions, which might work fine in this particular island, but we will never get the global scope out of that. One attempt is a project which I just would like to talk 1 minute about, where we try to, that's illustrating here the different e-health solutions as a cluster of different hugely fragmented things, to bring a little bit order into that mess and to arrange these different health applications in a way like you know it from your iPhone use, app stores, where you really can pick those in those tools you wish to use, and those which you are not finding interesting, you are not downloading them or not using them. So we arrange things in a project called SATMED. This is a European project in such a way where we have icons, and the icons illustrate different ways how you can use the different tools. And the tools means we start with things like, which is interesting for the national level, for instance, where you're collecting basic data in the different health centers so that you really know what the prevalence of a disease, what do I need to do to tackle a specific disease, how often is a medication used, what is the treatment applied in a different hospital. So at the registration in the health centers or hospitals, that's the basic information we need to plan aid and to plan a health system. If we have not this information available, we can't move ahead, we can't make things better. So that would be the first layer. The second layer is then maybe to go and see how the physician or the patient can benefit from these different things. There are tons of applications for radiologists, for cardiologists, for the topic we are talking today about giving birth, child and mother health, all these kind of things. And then the third layer might be even giving skills by education and training programs, which we know can be very well done through digital media. So education must not only be performed on the local site. So we have the MOOCs, we have tools like Moodles where millions of people participate, and they can be, of course, used for medical training too. We have rolled out these projects in different countries, including very difficult countries like Sierra Leone and Benin, Niger and Bangladesh, Eritrea and Philippines. And the global idea of the German country unit is to form out of these kind of experience with the new partners from Cameroon, Tanzania and Kenya, a kind of common standard, to define a standard where we can really share resources. That's also the subtitle of the Innovation Werkstatt, sharing ideas and resources and solutions, and have a more transnational approach of these ICT solutions for health. So which means we have at least a kind of minimum standard of technology and a minimum standard of data that we want to collect. And from there, we can then spread into the communities and into the more rural areas and do have a diversity of the applications. But we must have a shared platform which allows us to also share resources, which are sparse. And that's a little bit the idea how this could work. And then we are talking about tools which have already huge global footprint, like OpenMRS, with reported more than 4 million cases per year, Moodle, e-learning tool, like 5 million cases per year, so-called digital health information systems with more than 3 million reported cases, and no more new tools like Rapid Pro or Kobo Toolbox to unify them in the hospital information system environment, combine them in mHealth and aggregate them in the shared data platform. Data analysis, of course, is also very important. We need to make sure that our data has high quality, and also the data science aspects become more and more critical. So also here in terms of deep learning, machine learning, we have new tools in our hand to pull information about the collected data. And that's basically it. I just had 5 minutes. I think I used 7 at least. Thank you very much.
Thank you, Dr. Kuehne. I think what we've really just seen and what has just been presented are cool ideas. But they're not just cool, they're really solutions that are close to the heart of the people working at it. The participants of the Innovation Factory are all working in that area, and they've put a lot of effort into this in order to save the lives of women and babies. They're all unique ideas towards better health systems. They're making use of global experiences and local knowledge, and, of course, digital technology. So which leads me to welcoming and presenting to you the panel of experts, which is composed by the representatives from each country. And Dr. Kuehne and Stephen, you've already been introduced. Please come to the stage. And now it's ladies' time. Madame Achumi and Mawi Mlekano. Please, one more chair we'll need. Thank you. So Madame Achumi, she's a midwife and consultant from Cameroon. She's working on maternal and reproductive health. She's worked as a consultant and technical advisor to the GIZ. She has also been instrumental in, opening the first schools midwives in Cameroon, with 450 now that have a license to take care of antenatal and postnatal care services. She's organizing trainings of health workers, so furthering her knowledge about partograms and how to take care of women in delivery. We also have Mawi here. Mawi Mlekano, she's highly experienced in mobile health projects, development, community development projects, project management, and e-health. She's currently working as the executive director of the Invention and Technological Ideas Development Organization, short ITIDO, in Tanzania. She's, however, also the secretary of the mHealth Community of Practice, which is a group of experts and organizations steered by the Ministry of Health that is a platform for technical exchange, coordination, and cooperation in the field of digital health in Tanzania. So welcome again to the entire team. I would like to start this session with a couple of questions from myself to the teams, but you will also have later on the opportunity to ask your own questions. So my first question goes out to the global level, and that is to Dr. Kuehne. You've all worked in a really participatory nature on a global challenge through proposing local solutions. The German country unit somewhat goes beyond that level, and I would like to understand a bit more from you what global opportunities you see in strengthening these local solutions that are at stake. We actually have a few.
Have to jump back and forward.
Thank you.
Well, I just tried to convince you in my short talk about how important it is to really have shared solutions. I think if we don't reach a common level, at least a minimum standard, then we are lost. Simply because the cost will otherwise be too high to really push this digitalization through medical application in our target countries. And I think we will miss a huge opportunity to introduce these tools timely. There might be a gap otherwise of 10, maybe 15 years until we come to a second opportunity to introduce things like that. And I think digitalization, of course, it's not curing patients, but as I said, it's the fundament. It's really the fundament on which any healthcare system must build on. If I do not have any valid data, I can't make healthcare. If I do not know about what my patients are suffering at, I can't plan my healthcare. If the doctors are not having access to share expertise, they can't become experts. And all these things can be easily solved by digital tools which already exist. But we need political support. That's bullet point 1, which might be lacking. And we need also the willingness of the players to really agree on a standard form and a kind of format to push things jointly ahead. And that's why I think such a global approach is very important to realize the local approaches.
Exactly, great. Yeah, fully agree with that. Now, going from that global to the local level, what I would like to ask to Madame Achumi, since she's really, hands-on in the field. You heard the story of Dorothea. How would you say that a project like Happy Mothers would change the life of Dorothea? And how we've been talking about linking, we've been talking about systems. How does the project integrate within the health system?
Thank you. Good morning, everybody. Guten Morgen. And my first language is bonjour. I think we understand the story, and we have this story in much country. And we have an integrated solution with smartphone and a platform with 3 main functions. The first function is better information and home-based care with community health worker. And the second function is improved reference process. Reference process is improved communication between community health worker and the staff in the health center. Because here we have the problem of 3 delay. The time to take a decision to go to the hospital, the time to reach in the hospital, and the time to the staff of health center to take a decision. And now we have the evidence of data, of base community data are improved to take a good decision. I think that is the different opportunity that we can have with the smartphone and the embedded application, and also a platform with different sensibilization of community.
Thank you, Madame Achumi. We're talking about the potential benefits that these technologies can bring to the healthcare systems in low-middle income countries. And we've heard there are numerous efforts that are already out there, and some might actually even ask, so why do we need, even more projects that are going in that area? while integration and scaling up is yet to take place in many parts. So a question that goes out to Tanzania would be, how is the Innovation Factory and the project that you've been developing different from what has been done before? And how are you trying to overcome this challenge?
Okay, may I greet you in Swahili? Habari za asubuhi. Thank you. In Tanzania, we had a lot of mHealth and eHealth projects already, but the problem we are trying to solve is repetitive of those projects. And the problem is all these projects are just being implemented in the reached places. Those places which are hard to be reached, projects are not going there. So our innovation was to help the Ministry of Health to make all these projects be integrated and to have a system which will guide all the project implementers to know what to do and where to do. There is no need of repeating the same kind of project, the same kind of solution in the same area. And that's the problem we have. We might find projects that have been done in the same areas many times, 3 times, 4 times, and different results. Ministry need data. But data should be from all the country, not just a few areas in Tanzania. So we as implementers, we thought that it could be better if the Ministry of Health will help us to coordinate all the projects in Tanzania so that they can be implemented in the areas where we are not being reached to the standard of the ministry, not to our standards. So because at the end, the ministry is the one which needs data, the ministry is the one which needs improvement of the people. The ministry is the one which need good results, not ours. We are just partners to the health. So our aim was to change all that habit we have in the implementation process. We wanted to reach other areas which were not reached, but with coordination of the Ministry of Health.
Mm-hmm. Thank you, Moe. I think we've really seen, how different these countries are approaching this, but also where the commonalities are. So this is the question that now goes out to Stephen. We've talked about the individual context, but there are also a lot of commonalities, and there's both in the challenges that we are encountering, but also in the solutions that are being developed. So which commonalities do you see, and what do you see in advantage of working together on these challenges?
Thank you. I think for me, I see this, I would say, in 4 words, which are all starts with a C. So I think the first one is communication, collaboration, coordination, and continuity of care. In the sense that I think if you look at the fundamental challenges that we're all facing across the 4 countries, well, I guess the 3 countries majorly, the underlying factor really is just really lack of systems that promote continuity of care and which are powered by interoperability that is based on standards. I don't think we're going to stop the proliferation of systems which are very different from each other. I think the fundamental thing we need to focus on is how do we support continuity of care using standards-based interoperability, and that's really what we are focused on a lot, and I would say that's really the opportunity for us here.
Great. Cool. Okay, so, a question that really also goes out to the panel. Where really where have you seen the advantage of not working as an individual organization on the ideation process, but actually working as a team, working within your country, but also across the countries? And I really, it's a question that goes out to all of you.
I could start.
Yes, please.
The mic. I think the first one for me is learning from each other, and that way it helps us avoid mistakes and also uses the limited resources very wisely. Then I think I would say there's also a very growing, rapidly growing, I would say, trend where there's a growing need for digital global goods, common goods as they're called, so that reuse and improve rather than reinvent and recreate.
Thank you. I think that this project is welcome in the health system in my country because healthcare workers respond better to community need. That is the first problem. And the second is that community health worker is well integrated in the system. And the policy maker can take a good decision because the data is okay. And the serious problem that we have in the country is that community health worker is not a formal level. When it's not a formal level, it's not very well integrated. And we want that the project support the government, that we take community health worker, like a formal level in the system. Thank you.
To my side, this working together as group, we learned that in some issues we have advanced, others has not. So there is a lesson learned from one country to another, which can improve our health systems, but can help to solve the problem we have. There's no need of falling in the same pit, while others have already fallen and they know the way out. So if Cameroon has not yet reached that level, they can learn from maybe Tanzania, and we can learn from Germany and other countries. There's no need of repeating the same mistakes while others has already saved it.
Do you also want to add on that?
I just can say I totally agree, and I think the problems are not the same, but they are similar enough that we can form a joint voice to awaken a little bit the policymakers to support these kind of projects in the future a little bit better than they did in the past.
Okay, great. Thank you for your ideas on this. So, we've talked about that we need political support. We've talked about that we need minimum standards for building strong local solutions. We need to look at the systemic solutions that look at all the levels of the health system, and also especially at community health that has been neglected in certain areas. We need to look at the integration of system, rather than repeating solutions. We need to look at, I think you've summarized it very well with your 4 C's: communication, coordination, collaboration, and continuity of care. And in that also in creating a learning environment and, really sharing ideas. We too often, I think, sit in our own little, nutshell and think without sharing ideas. And I think that really that sharing ideas can lead to a lot of enhanced effort, like we've seen here. So now I think I really would like to give you the opportunity to also ask questions to our experts. Who has a question? And so, yes, please.
Thank you very much for the brilliant presentation. I'm Dr. Denis Samer from Cameroon, and of course I'm happy to see Madame Annie. So my concern is about this integration with the community. I think Annie rightly said it, that our community participation in health is not formal, has not been formalized. I've been doing benevolent work. And when somebody is doing benevolent work, you always call the community participation. Come and do this for health. Come and sensitize the women to come to the hospital. But they have to move to the health facility. They have to spend their time. And that one, the government has just been talking about community participation, but not thinking about the motivation. I'm so happy that now we're having this PBF, which is performance-based financing, which started by saying that, okay, now we have less than 60% of deliveries are done in our health facilities, meaning that more than 40% are still carried out in the community. And so all these traditional birth attendants, now what are they doing to motivate them to know that they can identify the risk factors and bring these patients to the hospital, or these women? Delivery is a natural process, but complications comes, and that is when we have the mortality. And I think with this idea of integrating, the community with the health facilities, that will be great enough to see that we can really minimize this mortality or these challenges. Thank you.
Thank you. I think what you just brought up is a really important issue, and that is the involvement of national stakeholders in the development of such ideas. And I think that's something that has been key in each of the countries. We've worked in teams where the Ministry of Health was also in the steering. So eventually, all the ideas that have been developed and are being developed, they're already in that sense integrated and address that level. And like in the case of Cameroon, I think the way the idea has been structured is actually through this project, you will also be able to very much inform policymakers of the needs that you were talking about, the needs to really formalize the system, really give community health workers not only a role but a formalized role in the system. I don't know if any of you would like to add to that.
Thank you. I agree. Welcome. I'm happy to see you. But the problem that we have again is the problem of traditional healer. You know that traditional healer and birth attendant, they give more service. And it's not expensive than hospital. But the second problem is some service in hospital are more expensive. And we have a serious problem in our country is the problem of midwife. You know that there is no midwife. It's not a long time that the school of midwife is open. And it's open since and closed. And we begin the new open in 2012, I think. And we have the first comma, and the two other comma are not integrated in the system. And that is the serious problem that if we want to work with the community, it's good to have provider. It's good to have a midwife to work with them. And I think that before I come here, I supervised the prototype test in one region with Happy Mother. And we have a delegate. You know what we say delegate is a chief in the one region of health who thought that she wanted that the level of community be formal in the minister. If we formal it is good. I want to support it.
Yeah, so let's hope that, you know, the way projects are structured, that can also happen. More questions from the floor. Where's the microphone? Yeah, okay, sure. Thank you.
Yeah, good morning. Habari za asubuhi.
Salama.
Yeah, I have one comment and then the question the last. I'm just giving you a little evidence what I've been talked about, the learning from each other, the lady said. We used to have, we are still going on, a collaboration between, we have the Hamburg and the Charité, together with Tanga Regional Hospital, along with Cameroon, Bamenda, in northern part of Cameroon. So this is the fund that we need now, because Hamburg and Berlin, they are high advanced, but Cameroon and Tanzania, they look like similar, they share challenges. So what we made it is a South collaboration. And now what we came in Cameroon, we found that they are doing better. So, in support of the ESTA project, we are supported to Tanga Hospital to go to Bamenda. We ran, they have a good functioning unit, so-called customer care. So we went to learn. When we went and learned, now we are doing fantastic at Tanga Region, even more than Cameroon, I can say, so sorry for saying so. So we're doing even better. So this learning from each other is better and a very strong tool that we can make up. So when we are coming up with a digital world, so learning with our situation, our colleagues from Kenya can come look now, as Stephen said, we are doing better in some extent than in mother and child, they have a communication. This is a good tool. But now coming up to of course, we are now having more opportunity than before. My friend from the Charity, we had a tool was technically supported by the Charity called the Hospital Performance Self-Assessment Tool. Now the problem is the sustainability. The sustainability is the challenge now. Well, now this the joint venture was almost over. Another project came in support. They just they're having implementers in the country, like Everplan. Now they are there, and now they're out. They came. Now we have an option UK. So the Everplan they came with also another tool focusing on the mother and child. In short time now, Everplan went out. Option came in with another approach. This is now the challenge. Now the question is, are you loving out loud? Really wonderful motto of the year. So are you looking at, in this digital world, is it coming now in your mind? Did it come in your mind, an issue of sustainability?
Just very briefly, I think really great thanks for this input. I think this is a key challenge that we are all facing, and that is that continuous fluctuation within development cooperation of different partners, different approaches, and not talking to each other, not trying to really ensure that sustainability. So I think this is a call that really goes out to all the ministries, that goes out to all the organizations that are supporting. But I think it's also a question, an issue that is trying to be addressed, at least in Tanzania, through the community of practice and others. So maybe Maui can also a bit add to that.
Yeah, what he's saying is true. I'm part of implementing organization, and in our community we are more than 70 organizations implementing mHealth. We saw the same problem, that today I have fund from GIZ, I'm implementing mHealth. Another one came in the same area with such kind of project, slightly different, with another approach at the same place. Mine has not yet been adopted by the government. The other one comes not yet adopted. No sustainability, no scalability. It's chaos. So we as community decided to have this kind of project that we need to push the government to set standards for all the projects we want to do in Tanzania, so that it can be easy for the government to adopt them when the funds goes out. If we want to collect data for DHIS, my project should be at the same standard with the others' project. So when I came, I do ABC. When somebody else came, should do EFG. And the other one should continue there, so that things can be scalable and can be adopted by the government. Not the way we are now in Tanzania. Everyone comes at the same place with the same kind of project, but slightly changed.
Which is probably why that the importance of what Dr. Kuehne was presenting is
the problem remains you in Tanzania are doing it different than your colleagues in Cameroon, and then we still have the fragmentation on a larger scale. So it's a first great step, and I'm really happy to see that the Tanzanian government is taking a little bit of responsibility at least. But I think we should even push harder and further to a kind of Agenda 2030, where we really force all the players to accept a common standard. And if this is not, and to have also a long-term plan how to homogenize it. And otherwise we will end up with the same what we have. It's a little bit, some things work, some other will not work. And this is a pity, because our resources are obviously endless, not endless.
I was going to add that I think if some of you have not seen this, there is 9 principles for digital development, if you have time to look them up, and they've really been formed out of these sorts of experiences. And I think they're really good collective principles that bind us, that I think should actually lead us towards forming a code of conduct, both as development partners and also as implementers, to also support government to implement this. Because these are really governance issues.
Great. And I think since you're saying that for the Tanzanian team, I'm sure you're welcome both to the community of practice and also, of course, to the Innovation Factor team to contribute with your ideas and the lessons that you've learned in your project, and also to welcome you to, I think there will be a presentation by, is it the Development Innovation Fund in Tanzania on exactly those principles of development of the Scapa community. So do get in touch with the team, and I'm sure that, that's a good start. Yes, please. Over there. A micro, please. Thank you.
Yeah, okay. Anne Schwarz from Brot für die Welt. So just a quick comment to what was just said about the need to push governments, or like an anecdote, because it's not only governments that help with this fragmentation. You all mentioned it before, but when I was in South Africa, there was this incident of actually GIZ and KfW accidentally basically proposing a very similar project, and the South African government then asking back, like, guys, are you talking? And they had their offices on the same complex. So it's happening everywhere. Bread for the World is also not that good in that, so it's a problem that also the development agencies and NGOs have to take to their heart, because the short end of the stick is with the executing partners and the beneficiaries. But what I actually wanted to ask is, first of all, Mr. Kuehne mentioned the political support that is needed. And I was wondering if, because two countries presented here, Kenya and Tanzania, you are in the East African Union, and I was wondering if something is happening there, in that sense, if there's any energy there between, I think that also includes Rwanda, I'm not so sure if there's any energy there. And the second question, basically to all the panel, because we're talking about mHealth here, not eHealth, as I saw. So I was wondering, is there an experience with, well, on the technical level, the most robust and best accepted technical features you're using? Are you relying more on SMS or feature phones, or is it more advanced tools you use?
Okay, two questions. Stephen.
Okay, so I can start with the one about the regional sort of governance. There's the East Africa community, I think, as most of you might be aware. But I think I would say practically, and in terms of just real functionality, nothing much is going on across the countries. There is, within the East Africa community, there is a sort of section, I think right now it's under Rwanda, for e-health coordination across the 6 countries in the East Africa community. But I would say country to country, cross-border, isn't as strong. But I think it's evolving towards that point. Yeah.
Thank you. I think in my country, EF is new. We have Gifted Month. Gifted Month is a project we make like EF that is begins around 1 year. We have to try to work together to see how to implement EF in the country. But we have much barrier like electricity. Shortage, access to electricity, the problem of road is not easy, but we think that can support provider to make the sensibilization and education in the community. Thank you.
I think I would like to, that last question that you talked about mHealth, eHealth, what are, the technical solutions that are out there that are already working and successful. I think I would like to pass that question to Lucy, because I think that's what their project is also about, looking at what projects are successful and how to integrate them.
Yeah, in Tanzania we have 2 sections. We have eHealth and mHealth. eHealth is much bigger, and mHealth is a small branch. mHealth is not only about SMS. We have some more advanced. We have a protocol for checking kids, their health activities. We call it, the name has just got out of my head. Steve can help me if he remembers. So we have more than SMSs. We have other protocols which are helping women and under 5. We advanced that a lot. Concerning the first question she asked about collaboration, it's much of political, I can say that, and big guys in the government. But in the little sense, not yet things has been done that way they are spoken. We don't have collaboration in health issues between Kenya, Tanzania, Rwanda, wherever it is in East Africa. Each country has its own stand, its own standard, its own policies. So we are not yet collaborated.
Yeah. Thank you. We only have a few minutes left here. I think what has really, there's a lot of things that have come out, and there's a wealth of experiences out there. So I think the first lesson is really, getting together, really sharing the experience that there is out there. I know, for example, Tanzania, they've done a mapping of all the projects that are there. Is it 120 or something that is there? So there is a wealth of experience. Get out there, ask for it, get connected. The names of the participants were on the last slide. Please just come forward. I think the other thing that we've really learned is the issue of, and it's a call for long-term thinking, for sustainability, for global standardization, and for using that for localized context, for looking at those principles of digital development that are out there, and really having a code of conduct yourself. I would like to pass on the microphone for wrapping up to Anna. Just say, last word.
Yeah, thank you. I'm Anne Talk, advisor in the Innovation Factory. No? Yeah, it's on? Ah, okay. And I just like to say thank you on behalf of BMZ, of the Ministry of Economic Cooperation and Development, and of GIZ for all the efforts that the health and IT health experts and IT experts sitting here as representatives of all the other people in your countries, in your institutions and networks, and that you really pushed forward the connectivity between the initiatives that are there already, and to help to combine and link between the different levels, really from the bottom up, from the mothers and the children, up to the government, to the policymakers, and all people in between, the medical staff and everyone who is important. And I just like to express my appreciation, and I hope that the concepts and the innovations will thrive. And I hope also that there are some contacts to have afterwards. And
Glad to the team.